And so I'd like to welcome our second speaker, re-welcome her to the podium, our esteemed colleague, Ann Lowry, and she is going to be talking about surgery for constipation. Still an option?
Thanks, Genevieve. So talk about going from the hot, new, sexy topic to the, however we describe surgery for constipation. You probably are all wishing you got up and there was a break. But anyway, that's my topic, surgery for constipation. I have no disclosures. I'm going to fairly quickly go through these two topics. One, slow transit constipation, what are the options for that, and outlet obstruction. I'm only going to talk about the top 3 causes of outlet obstruction. It's not an exhaustive list, but I'm not going to talk about rectal prolapse, stenosis, or anastomotic strictures, although I recognize they can cause it. So, slow transit constipation, the patients clearly need appropriate screening for underlying medical conditions, the side effects of medications, and obstructive lesions. I will point out that there is a very high incidence of sexual abuse in these patients, so it is important to sensitively ask questions about that. But if we're going to really consider surgery for these patients, then they need to have failed medical management, and there are a lot more options now for medical management of constipation than they were. They have to have an abnormal transit time, but it should look like the picture on the left, not the picture on the right, because if all the markers are in the rectus sigmoid, that's much more indicative of an outlet obstruction problem than a true slow transit. And the ideal candidate will have normal upper intestinal transit time, and you can see by this data from one study that that was under half of the patients, so that it's important to try to exclude a sort of total gut slow transit. The most common operation done for this is a subtotal colectomy with an ileorectal anastomosis. And in this review, they found patients did get better from the point of view of their constipation. The median was 3 stools a day. In the studies that used validated constipation scoring, they all statistically improved, and 85% of patients were satisfied. However, there are risks associated with it. There are the early risks, which up to a third or more had some complications despite a low morbidity rate. The most life-threatening risk is clearly an anastomotic leak, but the majority of the complications were early bowel obstruction or prolonged ileus, and that risk of small bowel obstruction continues long-term. And in one study that looked at did we really save medical resources, it found that 60% of them continued to need repeated ER visits and hospitalizations. So you can question how much better we've made them. And then, although their constipation has got better, it is in many patients accompanied by other problems. So frequent bowel movements, meaning in the way that was troublesome to somebody's quality of life, in 10%, urgency or accidental bowel leakage in 15%, recurrent constipation in about the same number, and the same number needed reoperation. Probably the most important thing to note is 40% had persistent abdominal pain. So you have to be really cautious about operating on people if the primary indication is pain. And it's so common for patients to think, well, I don't go to the bathroom, I have abdominal pain. You fix my going to the bathroom, you're going to fix my pain. And that is clearly not universally true. So this is the operation with the most data. In order to overcome some of the problems with that operation, people tried leaving the sigmoid. There's not very good data comparing the two, but what is there suggests that there's more persistent constipation if you leave the sigmoid. Others have tried leaving the cecum and connecting the cecum to the rectum. Sounds like a great idea, and some studies did show comparable results, but other studies have showed higher rates of persistent constipation and lower satisfaction. And it's always sort of tricky to figure out how to sew the cecum to the rectum without twisting the bowel. And the other option that's been tried are segmental colectomies, and these are based on the technology of doing segmental transit times and trying to see which segment is really the issue. There is limited data, and again, with conflicting results. And in addition, the technology to do these segmental transit times is not widely available. So in general, people who have had surgery for slow transit constipation are getting subtotal colectomies with ileorectal anastomosis. That operation has to be approached with a lot of caution. So, because it carries risks and there were problems, people looked at whether sacral nerve would be an option. There are 2 randomized controlled trials which were done after some early positive preliminary results. In one study, they put the permanent implant in all patients. The other study, they only put the permanent implant in people who responded to the test phase. In both studies, they had intervals of sham stimulation followed by intervals of stimulation in a random order. And the results in both studies were the same. There was no difference in transit time between sham and stimulation, and there was no difference in the clinical response. So although this would have been a great, easy solution, it doesn't work. Antegrade colonic enemas have been used in this country primarily in children. They have, however, been used much more in Europe in adults. And again, either using the appendix or a constructed conduit methodology for an access for giving yourself an antegrade enema through this port is constructed. This is a review from a few years ago, included almost 100 patients. There was a significant variation in the percentage that were still irrigating at follow-up. But of the patients who were irrigating, 2/3 up to 100% were satisfied. And of those patients, their bowel function, social function, and quality of life scores were improved. This is not really taken off in the United States, but it is used in Europe. To switch to obstructive defecation, the other category of constipation in which we might consider surgery. And again, I'm just going to cover these 3 diagnoses. Most of the patients with anismus are treated with biofeedback therapy, and many, a significant percentage respond and are able to learn to relax their muscle. But in patients who do not respond, another option is to inject Botox. This is usually in the operating room under sedation, and 100 to 200 units of Botox is injected in the puborectalis. It's been documented that it's safe with a low incidence of hematoma or infection. This is a review from 2 years ago that looked at 7 studies of almost 200 patients. Initially, 3/4 of the patients improved. When you get out to 4 months, which is past the time you would expect the Botox to still be working, about a little under half were still better. They were better if they had repeated injections, but the patients that improved were documented to have improved balloon expulsion tests, defecography, and EMG recruitment. And it comes with a fairly low, but 6% incidence of incontinence that does improve once the Botox wears off. So this is a safe option for those who fail, at least conceivably a safe option, those who fail biofeedback. However, this has not been studied in a randomized manner. Another option is a myotomy, and people were dividing the puborectalis. It had, as Kareem just said, incontinence through the roof, so people stopped doing that. And, let's see, you're right, this animation doesn't work. Anyway, there is a picture there someplace, but they do ischiorectal incisions, pull down the puborectalis, make a nick, so you have a partial cut of the puborectalis on both the right and the left. And this was compared in a randomized trial at 1 year and followed up with 1 year. And it was compared to biofeedback and Botox. The biofeedback and Botox arms had about 30% improvement at 1 year, and this partial myotomy group had 70% improvement. The trouble is, it's not that most surgeons are too afraid to do this because of the risk and would be technically very challenging in an obese patient. Rectoceles, the indications for repair are a little bit all over the map. They include symptoms, the symptoms you're all aware of for patients with rectoceles. They include size and grade of the rectocele, whether the patient needs to use vaginal digitation, whether contrast is retained in the rectocele on imaging. The balancing act is that rectoceles are very common findings on physical exam, so one has to be sure that they're really contributing to the patient's symptoms. A number of repairs have been described. I don't have time to go through the details of each of these repairs, but it can be repaired through the vagina, through the perineum, or the rectum. This is a summary of the data that was available last year looking at these different types of repairs. Again, the data was generally poor quality. There was fairly low morbidity associated with them. And overall, about 2/3 of them, or up to almost 3/4, improved. But if you looked at their specific symptoms, so only 38% improved the need to strain, 40% had a reduced sense of incomplete emptying, and 40% didn't need to digitate anymore. So while this combines to 70% improvement in terms of individual symptoms, it's under half of the patients. And even at 2 years, there was a 17% recurrence rate. They did not find any preoperative factor that identified or predicted the functional results, and they said there was insufficient data to determine the optimal repair. So, as Sarah pointed out eloquently, these rectoceles and other forms of prolapse often occur concomitantly with other posterior compartment prolapses as well as anterior compartments, and it's raised the question of should they be repaired together. It's clear if there's a full-thickness rectal prolapse that that's an appropriate indication for surgery. But the question now is whether about an internal intussusception. And again, caution needs to be used because this can be a finding on patients who are normal or at least asymptomatic. And so we don't want to say just because it's on the x-ray, we're going to fix it. But there is also a theory that this is a progressive process in which it will ultimately progress to a full-thickness rectal prolapse, and even as just an internal prolapse may contribute to incontinence or constipation. For many years, this was attempted to be fixed with the standard rectopexy. The results were very discouraging, and in my training, we were told not with a 10-foot pole. Don't go near them. They're going to be worse after you operate on them. Just treat them conservatively. But with the development of a ventral rectopexy, which you've just heard excellently described, there has been interest in doing this type of repair for an internal prolapse, in part because of the constipation improvement that's been seen. So this reviewed the studies done when a ventral rectopexy was done just for internal rectal prolapse. There are 1,300 patients in about 15 years, and 3/4 of them had an improvement in their constipation score. 60% had improvement in their fecal incontinence scores. There's a very low recurrence rate and minimum morbidity. They attempted to compare the results to those results of a posterior rectopexy with or without resection, and felt that the data did not allow firm conclusions, that there was a trend toward a lower recurrence with resection rectopexy, but there was more improvement in constipation scores and fewer and less serious complications with the ventral rectopexy. The STAR procedure, which I do not have time to go into the details, but is a procedure using a stapling device, again, much more common in Europe than in the States, in which basically the excess tissue involved in a rectocele and an internal intussusception are resected so that you go back to a normal configuration of the rectum. A review has been published last year of this. You can see it's a common procedure elsewhere in the world, as there are 8,300 patients included. The outcome data is fairly inconsistently reported, but about 70% are at least satisfied, some very satisfied. And using the criteria of a 50% reduction in the constipation score, about 70% improved. There is a very low recurrence rate. The complication rate is fairly low, but the trouble is that some of them are very serious. So in the early term, sepsis, rectovaginal fistulas, perforation of the rectum have been reported, and longer term, persistent stenosis, pain, and urgency can be a problem. So we have to remember we're operating for a benign condition, that it's unclear yet how much we're even helping people, and it does carry this risk, which is probably why it has not gained traction in the United States. So how do we choose patients? So obviously in all surgical areas, patient selection is key, but it probably is key with all capital letters in this group. If they have a normal transit time and normal pelvic floor studies, but they still have symptoms of constipation, surgery is not the answer. If they have slow transit constipation and their pelvic floor function is normal, and I would say abdominal pain is not the primary complaint, in very carefully selected patients, a subtotal colectomy would be a reasonable approach. But even in our practice with the big group, we do this very, very rarely. In patients in whom abdominal pain is a significant component, I would suggest it may be worth testing them with an ileostomy, and if their pain and constipation obviously improve, it might be reasonable to do a subtotal colectomy. If their pain persists, then you know the operation of a subtotal colectomy is not going to help them. For obstructive defecation, the process is often very complex in the pelvis. Therapy is clearly evolving as we learn more. If they have anismus alone, then conservative therapy with biofeedback is certainly the first step, and would consider Botox. In somebody else's hands, you could get a partial myotomy. If they have normal relaxation, the trend now is to repairing all the posterior compartment components with the ventral rectopexy in this country and ventral rectopexy and or STAR in Europe. If they have both non-relaxation and pelvic posterior compartment prolapse, I would suggest it's best to have them have biofeedback to treat the non-relaxation first, or to have a combined therapy plan in which they get biofeedback surgery and then more biofeedback. Thank you.